All right, good morning, everyone, and good morning to those online. My name is Clarence Wong. I'm the Director of the Division of Gastroenterology, and I'm covering for Dr. Kassam today. So it's my pleasure to chair this round. So I want to start with the land acknowledgement. So I respectfully acknowledge that we're located at Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota, Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. So it's my pleasure to introduce one of my, I dare say, our senior division members now, Mang. Maybe I shouldn't say that. But as a history, I still remember Mang, very young looking, this picture when I was a GI resident here, and he was one of the young staff. So Dr. Ma is a hepatologist, professor of medicine with the division in the Department of Medicine. He received his medical degree, his internal medicine, and his GI training here at the University of Alberta. He's won fellowship awards from AHFMR. And at that time, he was researching hepatitis B and molecular biology. He's won numerous awards, very distinguished awards, including the Castle Liver Education Excellence Award, the Excellence in Humanism Awards from the Faculty of Medicine, and also the Richard Fedoruk Memorial Award for Professionalism. He's been an examiner for many years in Royal College, yet it's definitely longer than me, but I think 2 terms or 3 terms. So it's my pleasure to welcome Dr. Ma today, and he's going to talk about MASLD. Dr. Ma.
Good morning, everyone. So this is a very hot topic, and hopefully I will be able to provide you with information about this important topic, which would have a significant impact in healthcare resource and costs in the future. So MASLD stands for metabolic dysfunction associated steatotic liver disease. So what I want to talk about, why is it important to have a pathway to care, and just the regular medical practice is not going to change the outcome for those patients until we change what we do. So for this talk, I have no financial conflict for this presentation. I do discuss treatment that have not been approved to be used for MASLD treatment. So it's important to understand why we need the primary care pathway and why we need to have a multidisciplinary management approach in order to really achieve good outcome for our patients. So I'm going to start with 2 cases, and both are very similar. 45-year-old man with abnormal ALT for over 10 years. Common liver diseases have been ruled out. Social alcohol user, 4 to 5 drinks per week, dyslipidemia on statin, mildly abnormal liver enzymes, normal INR, bilirubin, albumin, ferritin is a little bit high, platelet count 170. The other case is 52-year-old female with longer duration of abnormal ALT. Again, all the common liver diseases have been ruled out. Very occasional alcohol user, type 2 diabetes, and dyslipidemia. Liver enzymes, again, mildly abnormal, normal liver function, high ferritin, normal platelet count. From the primary care perspective, it's really hard to tell who has more severe fatty liver disease and who really need to be referred for care. So that's why we, in the last 10 years, we work on a primary care pathway so that we can get better care for patients with fatty liver. So when we talk about fatty liver, we really have to talk about obesity also, because there's a bidirectional relationship between the 2 conditions. So you can have MASLD before obesity or MASLD after obesity. So more than 1 billion people in the world living with obesity. It has been estimated 1.27 billion people with MASLD globally. And now they already have a major impact in healthcare costs and resource utilization. This will become even a bigger problem in the future. So in general, BMI is really associated with body fat. The higher the BMI, the more body fat we would have. And the new definition of clinical obesity is really increased body fat with organ dysfunction or affecting quality of life. Preclinical obesity means excess body fat, but with normal organ function. So by definition, MASLD patients already either would have preclinical obesity or actual obesity. So this is a study from the National Health and Nutrition Examination Survey. When they look at MASLD according to BMI, when someone has a BMI over 30, 50%, half of them would have MASLD. When they look at overweight, and almost 25% would have MASLD. Even when someone has a BMI between 20 to 25, you have really 15% with MASLD. And if you look at them closely, majority actually would have some form of metabolic dysfunction. So as you can see, the BMI doesn't tell you whether someone is going to get metabolic dysfunction or not. So it's a much more complicated situation. So this is the most recent publication looking at global prevalence of MASLD in adult population. As you can see in North America, almost 1 out of 3 adults would have MASLD. And some countries would be almost 1 out of 2. As you can see, this impact of MASLD in future healthcare costs and resource utilization would be very severe. So this is from Stat Canada. When you look at Canadian population, and you have 30% of the, in 2023, 30% of the adult would be obese and 35% would be overweight. As you can see, obesity is trending up over time in Canada. And you're talking about 2/3 of Canadian population either overweight or obese. As you can see, it's a major issue. And that will translate into more MASLD in Canada. This is a publication from Mark Swing from Calgary. And when they do the model, and they estimated from 2019 to 2030, and there would be an increase in 20% of MASLD in Canada up to 9.3 million cases. As you can see, we really have a challenge in the future how to allocate resources in looking after those patients. And with increasing prevalence, you're going to see increasing cirrhosis, decreasing quality of life, healthcare costs, society costs, further need for liver transplant, more cases of liver cancer. So this is a very simplified pathophysiology cartoon that I've chosen to illustrate the complexity of MASLD. We are all born with adipocytes, so we all have them. And how these cells behave with weight gain is highly variable. And their genetic predisposition, epigenetic change, environment, lifestyle, alcohol use. So with weight gain, and most people with some form of hyperplasia of the fatty cells, with this situation, you don't really have significant metabolism change. However, when you have hypertrophy of the fatty cells, and suddenly this lipid metabolism in your body and the oxidative stress will suddenly increase. With this hypertrophy, now it can be further modified by epigenetic genetic factors like certain genes like PNPLA3, lifestyle, alcohol, oxidative stress, and other inflammatory situation. And that's translating to obesity, fatty liver, heart disease, diabetes, and kidney disease. So this is the natural history of MASLD, and you start with a very healthy, shiny, brown-looking organ with genetic predisposition, lifestyle. There's a gender difference. The gender difference is actually need to be studied a lot more detail because in women, the estrogen really slow the activation of hepatic static cell, which form the collagen fibrosis. So premenopausal women actually has a protective effect from the estrogen. After postmenopausal, the fibrosis actually can occur very rapidly. So the natural history of women with MASLD is actually very different from men. And there's actually a document on animal study on some of the clinical data also. So 1 out of 4, 1 out of 3 adults will develop fatty liver. The liver become pale and maybe enlarged. And now they have fibrosis. 1 out of 5 will develop MASH with fibrosis. Almost 1% will develop cirrhosis. Now, not everyone with cirrhosis will go into liver failure. It depends on the age they develop cirrhosis. So if they develop cirrhosis at a young age, then more likely they're going to have liver failure in the future. So this would be the histological change from normal cells with fat, with the blue collagen tissue, and the nodular change in cirrhosis. The challenging thing would be from a normal liver to cirrhosis, most people don't have any symptoms. The ALT can be mildly abnormal, might even be normal. And ultrasound, the liver might just look a little bit echogenic, and the liver function would be completely normal. Now, the duration of progression is not linear either. People can have rapid progression. So in fact, now we see decompensated cirrhosis in someone in their 40s or even late 30s. So as you can see, this progression is really highly variable and depends on the age they develop MASLD and other influence that change the disease progression to cirrhosis. So what is important to realize that fatty liver by itself might not be a major influence on liver outcome, but once they develop fibrosis, the risk of severity of liver disease will go up. And once they have F2 fibrosis, liver-related mortality will go up. So the fibrosis in the liver predict more severe liver disease in the future and progression to cirrhosis and liver failure. Now, what is even more important is the fibrosis stage not only predict liver outcome, but overall mortality also. So in this study published in 2017, when they look at different stages, F1, just a little bit of fibrosis, F2 more, F3 a lot, and F4 cirrhosis in essence. So when you look at severity liver disease, not too surprised, someone with no fibrosis or little fibrosis, they don't develop severe liver disease. And when they have stage 4, they're more likely to have a liver worse outcome. But when you look at overall mortality, you also see the similar pattern. And someone with F4 fibrosis or F3, they have increased overall mortality also. So fatty liver really is a marker that something bad is going to occur to someone's health. So when we look at, so this is interesting in the sense that it illustrates that the care of fatty liver is really not coordinated. So when you look at mortality in overweight adult with MASLD, so if someone just had overweight, they have a certain percentage of mortality. But if they have obesity and MASLD, and their mortality will go up. And that's because they have really a generalized oxidative stress. This will actually increase risk of diabetes, heart disease, cancer risk, and many other health issues. And most of those patients actually would be being cared for by primary care or internal medicine. is only the one developed MASH, and they have the highest mortality because of the addition of liver-related mortality to it. And this other one we see, but we're actually not dealing with all those patients. And in fact, most primary care physicians don't know their patient actually has significant fatty liver. So there's a new definition of fatty liver. We call it steatotic liver disease. So we talk about the metabolic dysfunction associated liver disease. And then people want to break it down into whether alcohol consumption has any effect to it. So if someone don't drink very much, then it's mostly MASLD. If they have regular alcohol consumption, then there might be something alcohol component to it, and we call it MASLD. And obviously, someone with a lot of alcohol use, then they will have alcohol liver disease. But what I want to illustrate is this publication is just in October last year. And if someone has no steatotic liver disease, the long-term survival probability is actually pretty good. But it doesn't matter whether someone has MASLD or MASLD, they have compromised survival. And in fact, not that different from someone with alcohol liver disease. As you can see, MASLD alone is bad, and MASLD is not any, really don't add very much to MASLD alone. So what are the challenges in assessing patients with MASLD from primary care perspective? So the presentation is really, they have no symptoms, incidental abnormal liver enzymes. And most of the time it's really a routine examination discovery, monitoring for statin use, diabetes annual review, or from insurance. Once in a while, they have dyspepsia, they get ultrasound. The ultrasound said the liver might be fatty because it looks echogenic. So most people don't have any symptoms at all. So abnormal ALT is common. Majority of the time is due to fatty liver. And from the primary care perspective is patients are well, ALT is only mildly abnormal. Should they refer them at all or just monitor them? And in fact, majority of time they refer get rejected also. Prior to 2018, abnormal ALT, over 80% of the referral get rejected, or the wait time was over or around 1 year. From GI hepatologist perspective, we really don't have capacity to see 1 out of 3 or 4 adults for assessment. And for a long time, there's really no good treatment, and that actually has changed in the last couple of years. So what I want to point out is that a lot of patients we see in clinic already has advanced fibrosis or cirrhosis already. And by that time, it's very hard to change the natural history of MASLD, and the risk of liver cancer already exists. And for that reason, we are obligated to do ultrasound every 6 months on them. So that's kind of healthcare cost is huge on. If you do ultrasound every 6 months on 1 out of 10 adults, that's a lot of ultrasound, and the cost is substantial. So the classic medical approach to MASLD doesn't work. Most patients don't have symptoms. They don't even see a family physician, and they don't have a diagnosis, and obviously they don't get treatment. If you refer all MASLD to specialists, you really create this bottleneck effect, and patients get piling up. Very few patients actually get seen. So, and this is a situation we are dealing with all the time. And that's why 10 years ago, we started thinking how we can do things better. So with a grant from Institute of Health Economics, we actually set up initially what we call hepatology triage clinic. And then subsequently, we call it steatosis assessment fibrosis evaluation program. So a clinic run by nurse, and they provide efficient and effective assessment of the liver for PCP, no physician involved. They actually identify the right patients to be seen by hepatologists and how soon the patient will be seen based on the severity of fibrosis. And a goal is to improve wait time to see a hepatologist, and the approach would be acceptable to the patient and the referring physician. And we take the opportunity to also provide liver health information also. We can monitor the progression of MASLD. The goal is really to improve liver care through a much more proactive approach. So this is the wait time to see hepatologists. As you can see, from 2014 to 2016, the wait time to see hepatologists for non-urgent referral keep going up, and almost a year. And once we implement the pathway, and we drop the wait time by 58%. And we also improve median urgency referral wait time and also the urgent wait time also. So as you can see, we can do things better. How did we do it? So at that time, we actually looked at simple tests that can help us to determine liver fibrosis. Remember, fibrosis is a marker for MASH progression and adverse liver outcome. So we could use AST platelet ratio. We can use FIB-4 index, and someone creates something called a nephropibrosis score. So they are much more complex commercial tests that one can use. Unfortunately, none of them are actually supported by any healthcare community. And in Alberta, if you want to pay, you can get ELF tests also. And we also have FibroScan, which is vibration control transient elastography. We also have MR elastography in Alberta. And many ultrasound places would do shield wave elastography also. So the cost will keep increase as we go from simple tests to imaging study, and the wait time will go up also. So we look at the two scores more closely. So the FIB-4 is very simple. It's based on age, AST, ALT, and platelet count. And it's simple, and it's less than $5 to do the test. In fact, Alberta is the first province you can actually order FIB-4, and it will come back with the score for you. The nephropibrosis score is also simple enough, very similar, except now you need to determine the BMI, albumin, and whether they have impaired glucose or diabetes also. So, and those will require extra information. This is completely laboratory driven. You can do them as frequent as you want to, and if you choose to. What is useful about FIB-4 is it's a very good test for slowly progressive chronic liver disease. It doesn't work well for something rapidly progressing or acute hepatitis, but it definitely works very well for slowly progressive chronic liver disease. What we were interested was in this test because of the negative predictive value. If you have a FIB-4 cutoff of less than 1.3, you have a very good negative predictive value that someone don't have anything more than F2 fibrosis. So it's a very good test from that perspective. So we also have FibroScan, which actually is not funded by Alberta Health Service. It's actually funded by Hospital Foundation. In fact, we still try to get money from Alberta Health to buy us a new machine. And what it does is very simple, and it measures the softness or hardness of the liver. So vibration wave travel faster in a harder medium. So all it does is really monitor this vibration wave, how fast it will go through the liver. And it also gives you something called control attenuation parameter, which is a measurement of how much fat in the liver. So we do have this machine and this machine at the university. So when we look at FibroScan versus the gold standard MRI, if your goal is really want to choose the test with the best negative predictive value for fibrosis, FibroScan is not any worse, it's pretty much similar to MR elastography. When you try to separate stage 2 to 4 from stage 0 to 1 or stage 3 to 4 from 0 to 2, and you see very similar performance for FibroScan versus MR elastography. MR elastography does give you advantage in not only it can give you the fibrosis of the whole liver, but it has less limitation to obtain good results. But as you can see, if you want more detailed staging, MR elastography does have the advantage. But the test will cost $1,000 versus no cost in essence at this time in Alberta. There are commercial FibroScans you can get, and the cost is about $100. So this is the first publication that we come up with from this pathway. And most of the work is done by Tracy David Duke, which is the nurse we hire. And there's an internal medicine resident involved also on Mustafa. And what we look at is two strategy and taking all refer for MASLD. One model is to do FibroScan on all of them. And one we do FIB-4 first. If the FIB-4 is abnormal, we do the FibroScan. If we do a FIB-4 first strategy, we can save 87% of the referral that need FibroScan or need to be seen by specialists. There's definitely a cost saving there already. And only 13% will get FibroScan. And if the FibroScan abnormal, they will be seen by a hepatologist. So in this study, it's about 4%. And obviously now with this pathway fully running, we do run into a problem with BMI that beyond the ability our FibroScan can handle. I'm still looking for the new FibroScan that can allow us to do high BMI. And for that reason, this percentage actually has changed a bit. So now we're actually able to see, not only we decrease wait time, we're actually able to see all those patients that need to be seen. And some patients will get through because of other reason. And we're not perfect. We're going to miss someone with significant fibrosis. But hopefully next year we will pick them up eventually. And so it's not a perfect pathway, but we do get to see all the patients that need to be seen in a reasonable wait time period. So for a long time, people said, "Who cares? There's no treatment." And that has changed. But before we talk about treatment, I want to talk about determinants of contribution to obesity and MASLD. There's a physiological determinants, genetic predisposition, metabolic dysfunction, hormonal differences, gender, stress, depression, anxiety, sleep, and many other things. There's a behavior determinants, dietary habit, physical activity, lifestyle, cultural influence, and many other things. And there's a social determinants, access to healthy food, socioeconomic status, social stigmata, discriminations, and many things. However, government policy is actually also a very important part. You need education, preventive care, investment, and minimize commercial influences. So those are all important in the care of obesity and MASLD. So you need really a whole table of people sitting together, has a plan to really deal with this huge problem coming down the road. So you have the physician. Physician alone would not solve all the things because we don't have time. If we tell a patient to go and exercise, not much is going to change. So you need a dietitian, healthy eating. You need nurses to do FibroScan monitoring. You need support group. You need activity trainer to help establish healthy habits. And you need psychologists, psychiatrists deal with this anxiety and depression. You need government policy for education and allow us to implement a referral pathway. Took us 4 years in order to convince Alberta Health to allow us to implement the pathway. And it's really, even when they accept it as a good thing to do, they have to find the money to do it. So that's the challenge. So the government would have to really help us to really provide the best care. Now, there's no magic bullet for MASLD or obesity. Everyone's a little bit different. And there's a role for clinical research also that will allow them to get new treatment. And if the routine treatment don't or standard treatment don't work for them, and there's an opportunity to put them into clinical trial, look at new treatment. So this is how I see things. So we have the primary care pathway. We identify the patient and in the primary care home, and they can address diet, lifestyle, exercise. Hopefully they have the support of dietitian and different people. And we would help them to monitor the MASLD progression. There's an opportunity to optimize medical management of diabetes, dyslipidemia, and treatment for MASH is on the horizon. And for patients with F2 to F3 fibrosis, in the next 3-4 years, there will be treatment that they can go on. And hopefully we can minimize the number of patients that will need cirrhosis management. In order for us to be successful, we really need an integrative approach to really coordinate everything to obtain the best outcome for our patients. So I'm just going to talk about a few things briefly. And when people talk about diet, any diet can help someone to lose weight, but diet is much more complicated than just caloric content and nutrients. So I'm just choosing Mediterranean diet. Mediterranean diet is really less processed food with a lot of unsaturated fatty acid and more fibers. And this kind of diet is less oxidative stress and less driving the body into insulin resistance and improving the metabolic profile and improving the cholesterol. The diet also will change our microbiome. This change in microbiome in turn will cause gut homeostasis changes, and this gut homeostasis changes in turn will affect the cytokine, the oxidative stress, and the metabolic profile in our body. So it's much more complicated. And in fact, there's a role of manipulating diet to have better outcome also. We just need to know more how we can manipulate the diet. So I'm a big fan of intermittent fasting. For those of you who really want to learn more about it, there's a good review article in New England Journal. And intermittent fasting is really trying to trick the body into thinking about your exercising in a way. So it's really encourage your body to go into this bioenergetic challenge. When you exercise, your glucose get low, you go into ketogenesis. And intermittent fasting essentially try to encourage that also and try to turn on this metabolic switch, which is ketone to glucose switch. And in turn, it's really try to encourage different pathway to become activated and really improve cell growth, plasticity, and remodeling. And if you can really have this, establish these long-term adaptations, this is the outcome. You reduce abdominal fat, you increase insulin sensitivity, improve your lipid metabolism, healthy gut microbiome, reduce oxidative stress, reduce inflammation, reduce blood pressure. So it's a good thing, and many cultures practice intermittent fasting also. And but the caveat is, actually I have not seen the publication. So last fall, a presentation at the American Heart Association essentially look at using database recall, look at the effect of intermittent fasting. This is essentially what we call 16-8. So it means you eat only within this 8-hour duration and 16 hours no food. So in this study, it's actually concerning, and they said there's a 91% high risk of cardiovascular death. So I'm anxiously waiting to see the actual publication. And there's probably a lot of co-variable that actually, because a lot of people go into intermittent fasting, probably they have bad metabolic risk factor also. So there may be confounding things also. So, but this is something that create a lot of press. So next thing is exercise. And I'm choosing this meta-analysis to look at exercise, how that will change our metabolic system. So just to make things easy, I don't know how iPhone calculate VO2 max. In general, VO2 max is not calculable. You actually have to measure it. So what I've tried to make it simple is light activity with 1.6 to less than 3 MET, moderate 3 to 6, vigorous is 6 to 9, and a program of moderate to vigorous would be a mix. To give you some idea, when you sit quietly, you burn 1 MET. If you brush your teeth, that's 2. Walk slowly with a weight of 1 to 10 is 3. Swimming is 5. I'm a big fan of this. Rapid walking with, to the point your heart rate will go up, or a little bit solid breath. You burn about 6 MET. And running up the stairs, you burn 15. And this is what people call exercise snack. So if you do that several times a day, you actually achieve what an exercise program can do. So some people actually do that. In fact, one of the hepatologists in Vancouver he would go up the stair many times, and he's feeling like his BMI is probably 20. So to show you what you can achieve just by changing your routine. So this is what the 150 minutes come from. So we all learn about you have to exercise 115 minutes a week. So when you look at how aerobic exercise change body fat, in order to achieve this, you need moderate exercise intensity, 150 minutes per week in order to do that. And obviously, if you do vigorous exercise, and you actually lose more fat in the body. So you do need to do enough in order to change the body fat composition. Why is modest weight loss beneficial? A 10% weight loss is equivalent to 30% loss of visceral adipose tissue. So from a big abdomen with a lot of abdominal fat and fatty liver, you can reduce that to, in fact, you can completely resolve that. And by losing weight, you actually improve your lipid profile, improve your insulin sensitivity, and decrease thrombosis marker, decrease inflammatory markers, and improve endothelial function also. So what's the problem with exercise? This is a study looking at 52 weeks of diet and exercise. And if someone can lose 7 to 10% of body weight, there's a 64% chance they improve the fatty inflammation in the liver, and 50% chance fibrosis regression. And but unfortunately, only 9% of people can do that. So as you can see, is losing a little bit of weight is something someone can do in a year. Losing a lot of weight in a year is much more challenging. And so in order, we keep telling people to lose 7 to 10%, and only 9% can do that. And partially because when we tell them to do it, we really don't help them to achieve that. So you really have to, in clinical trial, the placebo group always would do better than historical data. Part of the issue is that when you come to see the clinical trial coordinator, they keep reminding you that you're gaining weight. Look at the scale, your weight has gone up, and have you been doing your exercise? So those reinforcements are actually quite important. So in general, modification of diet and activity can improve your weight by 5 to 10%. And but what's challenging is 50 to 80% of lost weight is regained within 3 to 5 years. So most people cannot maintain this weight improvement over time. So in anti-obesity MASLD treatment, and obviously if there's simple fatty liver, we start with lifestyle. If lifestyle doesn't work and their activity is compromised, we start thinking about adding additional treatment. And if they have fibrosis, now we need to be a little bit more proactive, try to improve this fibrosis and metabolic system. So this is not head-to-head trial. And this is look at obesity therapy. So if you look at bariatric surgery, it depends on what type of surgery being done. You can talk about 20 to 30% weight improvement. And when you talk about GLP-1, the newer GLP-1, which is either tirzepatide or semaglutide, you can talk about 15 to 20% weight improvement. And the rest of other medications are not commonly used, and the weight improvement is less. And all of that is actually blocking the digestion of fat, and it can help people to lose 5 to 10%. But the problem is if you block the digestion of fat, you're going to have steatohepatitis diarrhea, and it's a major issue. So this is semaglutide in MASH treatment and SN3 SN trial. And when the FDA dictate what the endpoint of those trials would be, so all the trials would have the same endpoint, is resolution of steatohepatitis with no worsening of liver fibrosis, or improvement of liver fibrosis with no worsening of steatohepatitis. As you can see, using semaglutide, 2.4 milligram dose, this is Wegovy, not Ozempic. Ozempic is for diabetes, Wegovy is for obesity. So it's a big dose, and not everyone can tolerate it. And so I'm not that interested in inflammation improvement. Fibrosis, remember, fibrosis drives outcome. So this is quite modest. So the treatment group, 37% would have at least one stage improvement of fibrosis, and the placebo group is 22%. This is tirzepatide, and again, this is improvement of steatohepatitis with no worsening of fibrosis, but I'm more concentrated on the improvement of fibrosis. The benefit is again modest. As you can see in this placebo group, the fibrosis improvement is actually quite good, 30%. So the improvement is modest. It's not a magic bullet. And some people actually can have a lot of improvement, and some people don't have a whole lot of improvement, and some people cannot tolerate it. So it's not a magic bullet. So this new medication called resmetirom is a thyroid hormone beta receptor agonist. And thyroid hormone has alpha and beta receptor. Alpha is the one that causes all the hypothyroidism symptoms. And the beta actually improve metabolism. As you can see, again, fibrosis improvement is modest. And it's not a magic bullet. Okay. And in essence, the treatment improves hepatic lipid metabolism and decreasing inflammation. So the new kid in the block is a drug called efruxifermin. How they come up with those names, I have no idea. So this is a FGF21 factor, which is something our body can make. And in essence, we give patient a big dose of it, and which really protect hepatocytes against stress and injury. And interestingly, people can have increased appetite but lost weight at the same time. So it's a very interesting drug. And so it does give you dose-dependent improvement in fibrosis. And obviously, people try to push a little bit how to, when you say stage 1, stage 2, you really don't quantify the amount of collagen. So now people start using digital pathology, which is exactly, so when the architecture look the same, but the density of collagen might be different. So now they start looking at digital pathology, and as you can see, and in 96 weeks, high dose can have 81% improvement. So this is in abstract form, but when you look at intention to treat analysis, and the benefit again is quite modest. So it's not like a magic bullet, 100% of people get better. So what is interesting about this medication is, and in a press release, that they said it can reverse early cirrhosis. So everyone is quite holding the breath to see whether this is truly a drug that can reverse early cirrhosis. So this is looking at bariatric surgery, major adverse liver outcomes, and comparing in compensated cirrhosis with MASH, and looking at non-surgical control. Now, those are not stratified, so how they select patients is not quite clear. Cool. Presumably, the non-surgical group is someone who don't want surgery. And as you can see, for compensated cirrhosis due to MASH, bariatric surgery might be something you can do also. The challenge in MASLD obesity treatment is really there's no magic simple solution. So you can improve the weight or improve the MASLD, but you need to maintain on it. If you stop the treatment, the weight will come back, the MASLD will come back. The only thing really much more persistent is bariatric surgery. So the maintenance therapy is quite important. As you can see, in the future, we're going to use a lot of those drugs for lifelong, and the cost for the society for healthcare would be huge. So back to the two cases. And if the family doctor knows this person has a FIB-4 of 2.32 and the FibroScan has a reading of 14 kilopascal, it will completely change how the primary care physician will manage this patient. And compared to someone with a FIB-4 less than 1.2 and a FibroScan is 7.4 kilopascal. So this person has MASLD, but don't have significant fibrosis. And the outcome in the next 10 years probably very good compared to this person. So the take-home message is MASLD and MASH are very common. The driver is really metabolic stress in association with the visceral adipose tissue hypertrophy. And advanced liver fibrosis not only associated with higher liver events, but overall mortality, whether it's heart attacks and breast cancer, gynecological cancer, and diabetic complications, things like that. If you can identify early MASH with fibrosis, perhaps there's an opportunity to change the natural history with much more proactive, stringent management of weight and fat dyslipidemia. And but overall, if we want to change this overwhelming health condition, we really need coordination with integrated healthcare professional and government to really try to change how we approach obesity and fatty liver. And we definitely need this multidisciplinary approach in order to get the best outcome for our patients. So everyone has a role to play. And as I say, I don't pretend I can get my patients to develop healthy habits. And I don't spend enough time to hassle them to stay on course to maintain their exercise and healthy eating. So everyone has a role to play. So I'm going to stop here.
Thank you very much, Dr. Ma. Incredible overview of what's changed and changed the guidelines. Maybe I'll start with a question first. So the pathway is really impressive at reducing wait times, but a lot of people are getting shear waves. How do you get that? Because they're going to the ultrasound. So how do you work that into your pathway?
Actually, I'm not supposed to say anything about that. We just finished a study with Chris Fung and with Calgary also. And so the problem with shear wave is definitely operator dependent. And the result is much more variable. And unfortunately, a lot of technologists are not well trained in doing shear wave elastography. So for that reason, we do have some problem with shear wave elastography.
Okay, so questions. Yes, Dr. Mason.
Thank you. I have a question about comorbidity. So when we look back on our transplant list, and when we couldn't diagnose hepatitis C, we subsequently found that everyone with the diagnosis of alcoholic liver disease actually had hepatitis C as well. So these diseases that interact, and my interest is mainly liver disease. When you look at patients with MASLD, which are the big interactive forces? Is alcohol a big interactive force? Is autoimmune disease or autoantibodies a big interactive force? Which of the worrying features do you see when MASLD combines with another feature that worries you?
Let me just repeat that.
Yeah, so how do coexisting liver disease interact? I don't think we know that answer. So in fact, there are data suggesting if you have chronic hepatitis B, MASLD might be beneficial. So we cannot really know that interaction. I mean, in theory, if you have two liver conditions, you would expect your outcome would be worse. But I don't know if we know that. And obviously, in autoimmune disease, for instance, and some of the medications you use might affect the metabolic system dramatically, and that will increase risk of MASLD. And but we actually don't know the answer. And in fact, the natural history changing, and we see some rapid progression. And used to be most of the fatty liver come to transplant in their 60s. And now they come to transplant in the late 30s. So there's a major change. And why? Well, we're not certain completely.
What do you tell your fatty liver patients if they say, "Can I have a drink?" Because I always tell my PBCs they're allowed one, and possibly restricted to weekends?
So it all depends on whether they are regular drinker or not. If they're a regular drinker, no alcohol. If they are really occasional drink, I don't see any problem with that. So once you tell them they have one drink become two become three, and very soon they will be drinking more than regular people. So it's easy to say no, and then no one bothers you. So.
Thank you. So,
Yeah.
knowing what you know of the natural history of this disease, if you were the Minister of Health, and you're far better looking, what policy lever would you pull?
Well, I think it would have to start in school. So this healthy living is really has to be really impress on the younger people first. And if you don't, you already lose half the battle already. So it's really important to have good health education in probably start in primary school and all the ways and to university, I guess. So what I can tell you is my youngest daughter is in competitive volleyball. And once they start become serious, they have nutrition session and everything. And once they learn about it, they are obsessed with it. So they just need to be taught and the benefit of healthy living. So it's important that the policy really, now we know so much about it, and not changing what we do is just not going to be something we want to do.
Okay, maybe time for one question online. Mang, is there any high quality evidence to support the notion that the gut microbiome can be changed by things that we do, like diet or supplements? Is there any evidence for that?
Yes, there are evidence for that, but obviously what would be healthy microbiome for one person might be different for another person. So it's hard to manipulate microbiome. The microbiome is how this microbiome interact with your gut function, the immune system, that in turn change the cytokine and hormones in your body. So it's more than just microbiome. It's the microbiome, how that change with your permeability of your gut and how your immune system interact with it. So it's much more complicated than just the bacteria in the gut.
Okay, maybe time for one more. A question, Dr. Ma. So a lot of people, they start lifestyle and then they take medications and then they kind of interchange the two. So there's any studies comparing medical treatment or bariatric surgery with or without the lifestyle changes, or trying to encourage people to, stay on maybe both?
Lifestyle change is always important. Doesn't matter whether you take medication or bariatric surgery, because the exercise do more than just it improve your balance, improve your muscle function, improve many things. So it's more than just changing your metabolism. So exercise is always good. Doesn't matter how old are you, actually. In fact, you can get someone in the 70s to exercise and they still can get benefit from it.
Okay, Dr. Ma, thank you very much. This was an amazing talk.